As a nurse, I hear a lot of patients question about the MRI in terms of gadolinium, because, that was in the news. Do we need gadolinium? Is gadolinium, going to become obsolete, or has it still got a place in scanning? Because patients and clinicians are confused about the whole issue.
We've had several meetings, both in the European group as well as groups in North America, around the topic of gadolinium. And one of the concerns that came up was there's some potential accumulation in the body of gadolinium, although it's meant to just be excreted after being used. We haven't seen any concerning toxicity in the central nervous system with that, but nonetheless, we want to minimize exposure of anything to people who are getting routine MRIs. And so what we determined was the use of contrast agents such as gadolinium are incredibly valuable, particularly in the diagnostic workup of patients. There's a lot of different diseases that can sometimes look like multiple sclerosis, and having that additional information that we get from contrast is so invaluable, as well as making an early rapid diagnosis, looking for dissemination of time with enhancing lesions. Gadolinium is just so invaluable.
And I would say early on, when you're following people, at least in my clinical practice, seeing what the sort of early magnitude of inflammatory activity is at the start, because that may actually change the way we treat people up front. Do we be more aggressive up front based on the imaging? And I think for myself, if I see a lot of enhancing lesions up front, I'm likely going to head towards maybe a higher efficacy therapy versus a modestly effective drug.
Well, that's why this program is so important, because the clinicians in the community are still questioning based on publications. And then the other question has come along, is the central vein sign. David, what have you heard about that? Or, do you think it's going to find its place in the guideline, or is it on wait and hold?
Well, we discussed it quite a bit at the meeting yesterday, because the central vein is a very important component of the findings that we do see on MR. The issue more has to do with the technology available now in terms of some of the sequences that are used to show that central vein consistently, and also how one evaluates for the central vein in the lesions. And there is still some practical issues of making it clinically feasible. And so it's another evolving aspect of it, and it's one of these matters where I think as we become more familiar with it and use it more in the research setting, it will definitely be translatable into day-to-day practice. And where we are at in terms of the guidelines is to say that for those sites that are able to do it, they would do it not as part of their core sequence, but it would be a highly recommended part of it, for which the sites that are able to do it will be able to do it and provide us with the information and the evidence for it. But for the core facilities that are doing it on a day-to-day practice, they would not have the capability of doing it.
Yeah. And it may also be superfluous in many cases. If you have a very typical scan with ovoid lesions already, where you can assume that it's perivenular and you have all the other stigmata in place, you don't need it. Whereas if it's a more dubious case where you're doubting could it be perhaps small vessel disease or something, migraine related, then you may want to turn to this additional sequence to make a choice, isn't it?
Yeah, I think that's a very important point, because many of the things that we do, MS has a very typical appearance, and certainly the Magnums group has been very good at educating us on green flags and red flags, and many of those are really based on the morphology of it. And some of it is central vein and some of it is not. So
it's nice to be able to show it's around the central vein, but if you see a typical morphology of the lesion, you can safely assume it's a perivenular lesion and you don't need to do it. Or if you have multiple short segment cord lesions already, then your differential diagnosis is almost nailed down, and you may want to skip that.
Yeah, I think in my view, where the central vein sign may be applicable is over time, when you're following a patient who may have comorbidities, hypertension, diabetes, and they develop new lesions on imaging, and you're considering, okay, should I switch therapies because I'm seeing new lesions? And even if it's in sort of the typical areas that we see, periventricular, et cetera. So that's where it may be highly valuable, because if you don't see a central vein sign in that context, maybe you'll step back and say, okay, this could possibly be a non-MS related lesion, versus if you see a central vein sign, then that, at least for me, will increase my index of suspicion to say, okay, this is pretty consistent with MS. Maybe we need to have that open conversation with patient and say, okay, maybe we need to switch therapies.
Here's a perfect example of how research has evolved into a clinical application, and I think that's something we've been dreaming about. So I think our meeting yesterday really showed us that it's possible.